Okay, so I'm going to get right into it. Thanks everyone for joining us here today. So I'm going to be talking about our research that has been ongoing around systems responses to violence against women across a select number of Canadian provinces, which I will get into. And just to set the stage for why this work is so important, and I know I don't need to spend a lot of time doing that with this audience. But we know that violence against women, including domestic and sexualized violence, increased during the COVID-19 pandemic, as has been the case in previous public health emergencies as well. And we know that this has also caused a great deal of stress across both social and healthcare systems. This is an infographic that was created early on in the pandemic by the Ending Violence Association of Canada, which did a national survey with providers of VAW services across the country that really emphasized the stress that was created by the pandemic, both in terms of growing caseloads, but also a lack of resources to respond appropriately to the really significant issues that were presented by the pandemic. Now, since March 2020 in Canada, there have also been a number of policy and other public events that have really brought newfound attention to violence against women. So, in the Maritimes, this has included the Mass Casualty Commission, the Desmond Fatality Inquiry, and the incident around the Sexual Assault Nurse Examiner program in New Brunswick, which led to an internal review of the provincial program. In Ontario, it also included the Renfrew inquest, which was the inquest into the murder homicide of three women by their ex-intimate partner, as well as the Ryan inquiry, which was again a murder-suicide in the context of intimate partner violence that happened in a hospital in Ontario. And then, of course, the announcement of the National Action Plan to End Gender-Based Violence, which was announced in Nova Scotia in November 2022. So with all of these different events have come new recommendations, in many cases echoing recommendations that have been long made by advocates, but really brought a new level of public and political attention of violence against women, and in particular, a real push to see the health system become more involved in an all of society-wide response. Now, the reason the health system is so important to responding to violence is that domestic and sexualized violence have severe consequences for anyone who experiences them's health. But that being said, while it has long been recommended that the health system play a more active role in responding to domestic and sexualized violence, the capacity of the health system to actually take up these recommendations has not been clear. And so that became a focus of our work focus around what is the capacity for intersectoral responses to violence against women. And just to highlight that specifically within Nova Scotia, although we see recommendations like this across Ontario and the Maritimes as well, there have been recommendations around seeing more training for frontline professionals in the healthcare system on identifying intimate partner violence, knowing the risk factors, and knowing what to do when it comes up. There's been recommendations for public health to become more involved in policy making around gender-based violence and violence against women. And then generally for both healthcare and public health as a whole in the health sector to be part of a society-wide response to gender-based violence and intimate partner violence. So we started the Interprovincial Violence Against Women Project, or the IPV project, which is conducting surveys and interviews with violence against women or VAW survivors and the staff who support them across Nova Scotia, New Brunswick, and Ontario to really understand what is the capacity for systems level response across healthcare and social care systems in these three provinces. And in particular, we were looking at how have supportive services for VAW survivors adapted since March 2020 with the COVID-19 pandemic and all of these newfound recommendations, and how well are these adaptations currently meeting the needs of survivors, including considering survivors facing different forms of marginalization. So for instance, due to racism, due to ableism, homophobia, etc. And then the goal is to take that knowledge that we generate and develop actionable recommendations that can improve service delivery and policy that is relevant to violence against women during and beyond public health emergencies. So the project is led by me as the principal investigator at Dalhousie, with other researchers from Dalhousie, UNB, U of T, and several hospitals in Ontario. And it's guided by an interprovincial VAW advisory group that includes representatives from VAW organizations and relevant government departments across our 3 provinces. And what was missing on that slide actually is that there's also a health system advisory group specific to Nova Scotia that includes representatives from across Nova Scotia Health, IWK Health, and community health organizations. Now, the health system advisory is specific to Nova Scotia because that piece of the work is funded by Nova Scotia Health. The whole project is funded by the Canadian Institutes of Health Research. So just to explain a little bit more about the design of the project. So the first stage of the project was conducting a short online survey with 3 different participant groups. The first surveys were conducted from November 2022 to November 2023 across Nova Scotia, New Brunswick, and Ontario, with VAW survivors and direct support and leadership staff working on VAW services. The next survey was conducted from November 2023 to February 2024, and that was with healthcare providers and decision makers in government, healthcare, public health, and community health organizations in Nova Scotia. The stage of the research that we are currently at and wrapping up is interviews with a subset of our participants who indicated they wanted to be followed up with, and then we've purposefully selected them based on a number of different characteristics, like where they are geographically, the patient or client population that they serve, or their personal sociodemographics. We've recruited our participants from a number of different methods, circulating emails and posters through professional association networks, directly calling organizations and individual contacts, attending meetings and events to share information on the project. We use social media. We did some in-person data collection in Cape Breton and New Brunswick. And we used public registries for licensed health professionals in Nova Scotia for the health survey. So going through the registries, contacting people directly, working in areas most relevant to managing domestic and sexualized violence. As a result, we have generated a sample of over 2,300 participants, about 650 from the VAW sector, including both survivors and staff, and 1,650 from the health sector, specifically in Nova Scotia. And these participants come from over 160 municipalities and over 200 organizations, including organizations across sectors. So we have VAW-specific organizations like Shelter and Victim Services. We also have housing and homelessness-specific surveys, so including homelessness shelters, justice and legal-oriented supports, family and child supports, sexual assault response programs, and the healthcare sector. What I'm going to focus on in the remainder of my talk is these 2 questions. So what we have learned about the health needs and outcomes of VAW survivors and the capacity of health and social care systems to respond to these needs. And in particular, I'm going to focus my time today on talking about the health system response, but happy to take any questions around our results related to capacity within social care systems. So the first question, what have we learned about the health needs and outcomes of VAW survivors since March 2020? So just a little bit of background around who participated in our survey for the survivor survey. We had 191 participants from our 3 provinces. Just over half came from Ontario, about a third from Nova Scotia, and the remainder from New Brunswick. Just under a third of our survivor participants access or try to access services in rural or remote areas. So we have done an urban-rural specific analysis where we look at differences across areas. For the sake of time, I'm not presenting those results, but again, I'm happy to take questions. In general, there were really more similarities rather than differences when we look at urban and rural participants. But again, Happy to take any questions if people are interested on that. So around survivors' health status, 1 in 3 of our survivor participants rated their health as fair or poor, which is the bottom of a 5-point scale. And 1 in 2 reported that their health was worse during the pandemic. So already baseline health is very challenging for most survivors, but we really saw a significant impact created by the COVID-19 pandemic. Close to 3/4 of our survivor sample reported that they were often or always experiencing a disabling condition, which is very significant. Most often, this was related to an emotional, psychological, or learning related disability. We also saw significant substance use among our participants. So just over a third were scoring at the high end of an alcohol use disorder scale, indicating hazardous drinking, and over a quarter were using illicit drugs. 7% of our survivors also experienced an overdose just since March 2020. So, in light of these really significant health issues, we also saw an impact on survivors' mental health, which we measured using the patient health questionnaire, which is 4 items around anxiety and depressive symptoms. They're scored on a scale indicating level of severity of the symptoms from none, mild, moderate, all the way to severe. And we asked participants about their anxiety and depressive symptoms at the height of the COVID-19 pandemic and in the last 2 weeks. So when we look at the height of the pandemic, we see that participant scores are at that very most severe end of the scale. But even when we look in the last 2 weeks, we see that their symptoms are at a moderate level. And both of these scores would necessitate or justify further clinical investigation into clinical anxiety or depressive disorders. So again, really significant mental health issues among our survivor participants and a major impact from the COVID-19 pandemic. Now, in light of these significant health issues, we saw high rates of healthcare access among our survivor participants. We asked them about the services that they accessed during the pandemic and those services that they wanted to but were unable to access. And the ones they most commonly indicated they accessed are also the ones that were most commonly indicated as wanting to but unable to access. And that included mental health and addictions, a family physician, and sexual assault aftercare. Given the significant proportion of our sample without a family physician and the acute health issues in our sample, we also saw high rates of emergency department access. So over a third of our sample indicated they access an emergency room just since March 2020. Now, this survey also included qualitative data, so we're not only capturing what are the services accessed, but what were the experiences like when participants actually went to access those services. And I want to share a quote from one of our survivor participants from New Brunswick on her experience in an emergency department. She shared, I've gone to the ER when on the darker end of suicidal thoughts to sit for 45 minutes without even being greeted. I'd arranged with a sexual assault nurse examiner or SANE to go in for an exam and x-rays to ensure there was no internal damage from her sexual assault. It took weeks before I could commit to going. When I went, the triage nurses wouldn't go get the SANE nurse who was just around the corner. They wanted me to sit in a packed waiting room. I explained my situation, visibly shaking in distress, and I ended up leaving, not getting any of the tests I need done. Now, if we were just to have a checklist of services accessed, this is checked off on this participant's survey. But obviously, the story reveals a much more nuanced experience that we actually really wouldn't consider successfully accessing emergency supports. And while there is very likely much more to this story, including the staff perspective and the overwhelm and overburden of staff, which is the goal of the next survey I'm going to show you results from. It really tells us an important story around what the experiences are currently like of survivors trying to access healthcare supports and the ways that oftentimes they are re-traumatized when doing so, really emphasizing the importance of a more trauma-informed and more violence-informed healthcare response for patients and communities. So, our results demonstrate significant unmet health needs of VAW survivors. We see many challenges in accessing health and social services, including not being able to access services when needed. And there are many shared experiences across rural and urban areas. There are some differences in rural areas that really emphasize the need for sustained investment in technological infrastructure and coordinated interorganizational strategies to ensure timely and equitable access to services in rural areas, including during public health emergencies. And again, happy to chat more about that if people are interested. But moving into the current capacity of the health system to address these significant health needs among survivors. So, our health survey included over 1,650 health professionals who participated from all health zones in Nova Scotia. Our participants come from a diverse array of specializations, but we really prioritize those working in areas most likely to be managing issues related to domestic or sexualized violence. And so you really see that reflected in our participation on the left-hand side, most participants coming from mental health and addictions, primary health care, maternity and childcare, and emergency or critical care. These bottom three services, community health, sexual domestic violence response, and sexual and reproductive health, are smaller numbers in terms of the proportion of our sample, but these are also smaller program areas. When we've estimated response rates, we actually see quite a significant response from these program areas. For instance, for sexual and domestic violence response, we've estimated our response rate is 50%, so 1 in 2 people working in these areas, which is a very strong response rate. So when we consider the roles of the people who participated in our survey, most commonly they're engaging directly with patients, community members, or clients. About a third are managing people in patient-facing roles, and then 147 are in roles that are more policy, research, or program-oriented. So, to summarize our results, which our survey was focused around knowledge and practices related to domestic or sexualized violence among our participants, 42%, close to 1 in 2 of our participants, reported seeing at least one case of abuse in their work in the last 6 months. 12% reported seeing 6 or more cases in just the last 6 months. That being said, the vast majority of our participants reported they had had no training on domestic or sexualized violence since March 2020. This is true of those who are seeing recent cases of abuse as well. They reported inadequate referral resources at their work sites, not knowing where to refer to in the community. And they also indicated they don't have any access or collect data around domestic or sexualized violence, which means we're also not able to currently estimate the prevalence of domestic or sexualized violence among patients in Nova Scotia's healthcare system. This is the case really across provinces. And also, we don't have a ready-made monitoring and evaluation system for when we do implement new intervention strategies to see how well we are doing. In addition, among our participants who were involved in COVID-19 policies or programming, they indicated that they rarely considered the needs of VAW survivors when designing or implementing these policies or programs, which is quite significant given that we know from previous public health emergencies the impacts that infection prevention and control policies have on violence against women, including sheltering in place, which of course leads to survivors of violence needing to shelter in place with abusive members of their household. And most often, they described their work as trauma-informed, equity-based, and people-centered, which is telling us that they don't see violence as relevant to these approaches. So these are all areas that we are currently exploring in our interviews to better understand, for instance, what do these approaches mean to people working in the health system? What do their current referral resources look like? What does any training that they have received on domestic or sexualized violence look like? And when they are identifying cases of abuse, how do they determine this? And what, if anything, do they do for those patients? Now, we also asked participants a series of questions related to their opinions on violence. So the first set of items were related to their individual level attitudes. This included a scale around victim understanding. So an example item is victims of abuse could leave the relationship if they wanted to. So these items were scored from 1 to 7, with higher scores indicating a better preparedness to respond to violence among patients. So a score here of close to 6 out of 7 on victim understanding suggests our participants are not holding victim blaming attitudes, which is good and is an important step towards being prepared to respond to violence among patients. But when we consider more organizational or systems level issues, we see much lower scores. That includes workplace issues. For instance, my workplace encourages me to respond to domestic or sexualized violence and preparation. I have the necessary skills to discuss abuse with a survivor. These are scores of less than 4 out of 7. Again, in contrast, really showing a lack of organizational and systems level support to be managing and responding to violence among patients or within policy and programming. So, our results provide an in depth snapshot of the state of health system capacity to respond to domestic and sexualized violence across priority program areas like mental health and addictions, emergency, primary health care. Um, and this included roles that are patient facing and not patient facing, which both have an important role to play in managing violence. There are significant gaps in the current capacity of Nova Scotia's health system to respond to violence. And there's a clear need for more training and expertise, improved knowledge of internal and community resources, and stronger organizational directives and protocols. And more funding is needed for a coordinated systems response. So it doesn't just fall on the shoulders of the healthcare system to be responding to violence, but health should play an important role in intersectoral responses. But we need appropriate investment into this kind of approach. Given the health and social inequities faced by VAW survivors, which our surveys help to demonstrate, it is critical for healthcare services in Nova Scotia and indeed across provinces and territories to be better equipped to respond to VAW. So, in the remainder of my time, I want to focus on where do we go from here? So just in terms of the IPV project, which is from where these surveys come from, we are conducting further data analysis and knowledge sharing with peer-reviewed publications on the way, and we are in the process of wrapping up our interviews. But I'm very excited to share that we've also received new funding from Canadian Institutes of Health Research to support action-oriented research across Nova Scotia, New Brunswick, and Ontario on strengthening the health system's response to violence against women. So I want to talk a little bit around the stages of this new research and also our ongoing longer term goals for this program of work. So the first step that is critical in order to designing successful intervention and policy strategies is really understanding the problem and determining where there are currently gaps in policy and practice to addressing and preventing the problem. The next step is identifying opportunities for evidence-informed change within existing initiatives and priorities. Where we want to go from here is implementing what we call an advocate-based model to responding to domestic or sexualized violence in the healthcare system. And what this means is that we don't expect that all healthcare providers will become experts on domestic or sexualized violence. We know we don't have the resources or capacity to do this, nor are all healthcare providers appropriate to be the ones who are responsible for specialist care around domestic or sexualized violence. So instead, we want to see advocates embedded within the system who hold that expertise and who can be referred to manage that ongoing specialist care. And what we think would work best for those advocates are the sexual assault nurse examiners who are trained to respond to domestic and sexualized violence, as well as appropriately trained social workers. So in the Nova Scotia context, we have our sexual assault nurse examiners, as well as domestic violence consultants, who are a new cohort of social workers trained to manage follow-up care around domestic violence in the health system. And this is a model that has worked well internationally, most notably in the UK, where they have independent domestic violence advocates who are embedded within different sectors, including health, and who are referred to when violence comes up among patients in priority areas like primary health care, like emergency, maternity, child care, and more. And so this is the kind of model we want to see. So it does involve a baseline level of training and understanding so that all healthcare providers know how to appropriately ask their patients about violence and safety in the home. They know what risk factors to look for. But then when violence comes up, they know who to refer to within the health system who can then support some of that more specialized work, like, for instance, safety planning, in-depth knowledge around resources in the community, and more. Eventually, a longer term goal of what we want to move towards is what is called a health in all policy approach. And we kind of tack onto this a health and violence in all policy approach that addresses the social and structural determinants of health and violence, which are shared across the lifespan. And so, this is really the idea that it's not just the sphere of health policy that impacts the population's health. It's all areas of policy that can have an impact. So, for instance, including economic policy, education policy, labor policy, et cetera. So, we know all of these different areas of public policy and social policy have an impact on people's health. And so, we need there to be expertise within all of these areas around how their policies might intentionally or unintentionally impact outcomes related to violence and where there are opportunities for preventive policies. Now, the role of our research team is really supporting the identification of best practices and the design of implementation strategies that allow for ongoing monitoring and evaluation. So, we cannot, of course, actively resource the healthcare providers who are going to be embedded and become experts around these issues, but we can support on how do we implement and evaluate this in a way to put forward the best available evidence on these new intervention and policy strategies, and what does the best available evidence tell us is most likely to be successful. So, in terms of where we are going with our newly funded intervention research, we're working with Nova Scotia, Ontario, and New Brunswick around this staged approach. And the starting point is a little bit different depending on province. So for Nova Scotia, where we've already done a needs assessment in both the social care system and the healthcare system, we are able to move on to identifying opportunities for evidence-informed change within existing initiatives and priorities. But in Ontario and New Brunswick, where we have yet to do that health needs assessment around current capacity to respond to domestic and sexualized violence in the province, we are working on our problem definition phase. And I'll get into a little bit what the goals are for each jurisdiction. So for Nova Scotia, we're working with 6 priority areas in the health system to design, implement, and evaluate evidence-informed strategies for managing VAW. So that includes mental health and addictions, maternity and childcare, public health, primary health care, and emergency. And then across all of them is the violence prevention, intervention, and response team that's relatively newly established at Nova Scotia Health, and our sexual assault nurse examiner programs. We're also working with executive leadership and information management and information technology and our new health record system, One Patient, One Record, on how to safely and appropriately collect data around domestic and sexualized violence among patients. And across all of this work, we continue to work with an advisory of VAW and allied organizations across the province. In New Brunswick and Ontario, where we are focusing first on that needs assessment, we have our ongoing partnerships with community VAW and allied organizations, which we continue to grow. And then we are working with priority health system actors to start, which are those embedded advocates in the health system. So in New Brunswick, that includes the provincial SANE program. And in Ontario, it includes the Ontario Network on Sexual Assault and Domestic Violence Treatment Centers, which are the sexual assault nurse examiner programs operating in hospitals across the province. And then the goal is to build out from there. Building our partnerships and engagement with priority program areas across the health system in New Brunswick and in Ontario. So, to sum up, there has been tremendous change in the lives of VAW survivors and in health and social service sectors since March 2020. Our data provide a unique snapshot of the state of health and well-being needs among VAW survivors across provinces and insight into the current capacity of social and healthcare systems to respond to these needs across Canada. There really has been an opportunity that has been created by this new public and political attention around VAW that really highlights the importance of determining, advocating for, and implementing the nuanced structural changes that will be necessary to improving the lives of VAW survivors and the staff who support them. And so, our new funding from CIHR is an important step forward in producing evidence informed, systems wide change in the health sector, as well as in strengthening intersectoral responses to violence. And it is the start of a long road in a program of work, absolutely. So just to sum up, these are all of our funders who we, of course, gratefully acknowledge. And if anyone does have any questions you want to take offline, you can reach me at my email address. We also have a website, www.vawresearch.com, where you can peruse all of the knowledge translation outputs we have produced to date, summaries of all the different projects, and some of our media engagement. So that is it from me, and thank you all again for joining today.